Right. If you have read and understood, considering a clinical examination station, kindly begin. Kindly begin.
Hello, ma.
Yes, begin, please.
Okay, all right. First of all, I would want to introduce myself to I want to wash my hands. Then
Yes.
I will introduce myself to the patient. Then I would also want to confirm his name and age. Then I would
Okay.
want to explain to him what I want to do.
Yes.
I would which will entail to watch him walk, to give him certain instructions, and also perform certain movements.
Yes.
And if, however, he's having any pain, he should let me know. I'll be gentle with him.
Yes.
Then exposure, I need him to expose his upper limb, to expose his lower limb, so he can just be on a singlet and a shorts,
Yes.
or his briefs. So I'll start my examination by watching him walk initially to look at his gaits, but I'll stand by his side to support him in case so he doesn't fall. So I expect him, if he has any form of cerebellar pathology, he might have an ataxic gait. So I would look at his gait. I would watch him walk towards for a particular distance and also come back to me while I assist him. Then I would want him to also perform the tandem walk, that is the heel to toe walk. If he can, I would watch him if he can actually perform it. Then subsequently, I would want him to now close. I want him to stand, close his eyes, put his arms by his side. Then I'll put my arm. I'll put both of my palms behind and also in front of him to see if there's any form of deviation, and this will just assess his dorsal columns of the spine, not really a cerebellar pathology. So once I've done that, the next examination stages will be done while the patient is sitting. So once he's sitting, the first thing I would want to do, I would ask him again if he's having any pain or if he's in any form of discomfort. Then I would look at his eyes. I'll tell him what to do. I'll make movements like H, in a H pattern to assess for nystagmus. Then once I've done that, I also want him to talk. I'll tell him to say something like British Constitution. If there's any form of staccato speech, I would also take note of that. Then once I've done that, I would want to assess the last 4 cranial nerves, which is the glossopharyngeal, the vagus, the spinal accessory, and also the hypoglossal. I'll assess the glossopharyngeal and the vagus by telling him to open his mouth. I'll look at the uvula. If there's any form of deviation, I'll tell him to say ah. Then I'll also tell him to cough. Then the spinal accessory, the cranial nerve 11, I will assess that by telling him to shrug his shoulder against resistance to assess the movement of the trapezius and also the sternocleidomastoid by moving his neck towards against resistance, also to the right or to the left. Then I'll also assess the hypoglossal nerve by telling him to open his mouth, stick out his tongue, or close his mouth and also blow his cheek and stick out his tongue. Just move his tongue. Just assess the tongue muscles, which are mostly supplied by the hypoglossal nerve, except the palatoglossus. Then once I've done that, then the next will be I would want to the upper limb. I would want him to, first of all, I'll tell him to stretch out his arm in a supine. I want his forearm to be supinated with his palm facing up. Then I'll initially pronated. I'll watch for any form of intention tremors. If there are no tremors, or if there are, I'll take notes. And I'll tell him to stretch out his hand, ensure that the palm face upwards. Then I will look for any form of pronator drift. I'll assess if there's pronator drift. Then also I would hit the arms to see if there's any form of a rebound. All this might be positive in a cerebellar disease. Then once I've done that, I would also want to assess for, I'll stay a few distance away from him and I'll tell him to use his index finger to touch the tip of his nose and also touch my finger at a particular distance. I will tell him to do this severally to assess the coordination. Then subsequently, I'll tell him to open his one of his palm, then pat the other one, the palm and also the dorsum of the hand. I'll tell him to do that severally to assess for any form of dysdiadokinesia. I'll take note if he can do it or if he can't. Then also, I will now want to assess the tone, the muscle tone. I'll ask him if he's feeling any pain, and I'll tell him I'll be gentle. I'll help him to move the upper limb, to flex the elbow, and also to extend in a gentle way to assess the tone of the muscles. Then the reflexes, I will assess the biceps reflex. I would first of all tell him to flex so that I can identify the tendon of the biceps tendon. Then subsequently, I would use my reflex hammer to check for the reflex. Usually for a cerebellar disease, there might be hyporeflexia. Then once I've done that, then the next will be the lower limb. In the lower limb, I also want to assess the tone of the muscles.
Can you
and also
present your examination now? Okay.
I have examined a 49-year-old male with a 49-year-old male that has an ataxic gait. Yes, dysdiadokinesia. He has intention tremors. He has and also there is a hyporeflexia and hypotonia in his muscles, and he also has intention tremors. Okay, so what are your differential diagnosis? My differential diagnosis is a posterior fossa tumor, most likely a cerebellar tumor, and also it could have a trauma. It could be a trauma to the brain. It could be a cerebrovascular accident. It could be a transient ischemic attack, and it could also be a metastasis from a lung or a breast cancer. It could have a metastatic lesion. Can you can you tell me a few posterior fossa tumors that you know of? Okay, posterior fossa tumors include a cerebellar astrocytoma. It could be an ependymoma. It could be a medulloblastoma. It could be a hemangioblastoma. It could be a dermoid, and it could also be how should this patient be managed? This patient investigations. Yes. Yes, I would want to do a CT of the brain. I'll do a skull X-ray. I'll do a CT of the brain. I'll do a magnetic resonance of the brain. And also, I would also do a chest X-ray to see if there's any form of metastasis to the chest because of the tumor, to know the severity of the tumor. Then, yes. What treatment options can you offer to the patient? Okay, the treatment options depends on what my diagnosis is. For tumors, once I've staged, I would want to excise the tumor. However, if it's an advanced stage, you might also benefit from chemotherapy to debulk and downsize the tumors before my definitive surgery. Good, thank you. One thing more, when you were presenting, it would have been good if you could have said that if time would have allowed you, you would have completed with the leg examination. The rest I was noticing very carefully. You mentioned all of them. For reflexes, did you mention the reflexes of biceps, triceps, and spinator? Yes, I mentioned the reflexes of the upper limb. Upper limb, yes, but these three in particular you have to do, like biceps, triceps, and spinator. And then lower limb you forgot to mention, so there you could have knee-jerk reflex. My time was up. Yes, you could have said, like, if time would have allowed you, I would have completed my examination with the lower limb examination, because that was missed. So rest it was good. Excellent. Yes. And I didn't do my coordination, the heel to shin for the lower limb. Yes. Yes, that you can also mention. You did do the stance, you did do the stability in tandem. Heel to toe was tandem, you did that. And Romberg's test you did, speech, nystagmus. I think you covered everything, even proprioception you did. It was just the leg examination which was left. Yes. And coordination comes in leg examination, you know. It's the tone, you look at the leg roll and leg lift, and then the reflexes, the knee and ankle, and then the coordination. Yes, ma. Yes, ma.
And you could say, in order to complete my examination, I would do full neurological examination, including the cranial nerves and
Yes,
the
ma'am.
legs that you have missed. So that would have completed. Good.
Thank you, ma.
Thank you.